Good afternoon, this is Sarah with the Department of Medicaid. It's not quite 1 o'clock and we are still clearing out the waiting room, so we'll give it just a moment before we get started.
Okay, thank you.
Sounds great. Thank you.
It is one after one, and our waiting room is cleared. So if you would like to begin, I will turn it over to the TAC.
Okay, thank you, Aaron. Appreciate it. I've counted 6 out of the 7 of us on the call, so we definitely have a quorum. Just need a motion to approve the minutes from the previous meeting on February 14th of 2024.
So moved. Second.
First by Rosemary, second by Matt. Any further discussion? All those in favor say aye.
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 Any
Can
opposed?
all voting members please have your camera on?
Okay.
Thank you.
And then under old business, one thing that I want to bring up, obviously the list came out for Kentucky on all the providers that can manage and order community health workers, and of course we weren't on it. I need some action items because I know the Government Affairs Committee with KPHA were at least considering some community health worker statutes that can put us in there, because it's if, in my opinion, if Kentucky Medicaid wanted to have the most hands-on people to be community health workers, you would be enlisting every pharmacy technician you could, managed by pharmacists, because in other states, they're the ones doing the bulk of the work. Things that we do on a normal daily basis, like well checks. A lot of our delivery folks are pretty consistent with, especially our homebound people or even bedridden people. Obviously, if something's out of order, we go ahead and do well checks, or at least get the police to do a well check on somebody. I mean, just simple things like that we do all the time. And our people could be doing that. So I would like a motion from somebody that we would encourage Kentucky Medicaid to include pharmacists on the list that can supervise and provide and manage community health workers. And we're going to be obviously looking at this too, because on the statute side, so it's going to be taken care of one way or another. It's just a shame that it wasn't done initially for Kentucky. So does anybody have any comments on that or a motion?
Ron, this is Meredith. I'll
Yes.
make a motion to pursue adding pharmacists as prescribers to order CHWs, or I guess to allow CHWs in pharmacies and pharmacists to be able to order those services.
Okay, got a motion by Meredith. To have a second?
I'll second that.
All right, second by Rosemary or Paula, second by Rosemary. Any further discussion? Okay, all those in favor say aye.
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 Any opposed? Okay. I encourage you to look at the U.S. Pharmacist article they have on community health workers, and I believe it's Trip Logan in Missouri that's got like 18 of them and the services they're providing. And it's really it's a whole lot more enjoyable for the technicians because they can work, 2 to 4 hours on their community health worker work, and then the rest of the day they're working as pharmacy technicians, and a lot of those jobs go hand in hand. But anyway, we've unofficially had some really good intervention success stories ourselves, and I'm sure every pharmacist could say that, especially in the community and being a part of your community. I don't know if Jennifer is on here from account executive at Med Impact, or anybody else that wants to, or the lady from Anthem even that was helping out with the HPV vaccine update, because I know that's been going on for some time, and we don't, as far as I know, we don't have an official protocol as of yet. So I didn't know if there was somebody on the call that could shed some light on where we're at on that HPV statewide issued protocol.
Yeah, Angela, do you want to give any updates? I know some of it is still in review with DMS, so we're hoping to keep the ball rolling and continue to review it.
Hey, Fatima and Ron, it's Angela with
Yes.
Anthem Blue Cross Blue Shield. We have the protocol, we have the point of sale messaging. The MCOs have sent the files to the members for the point of sale messaging to come up on your all's end. So we're just working on Med Impact, finishing up that part.
So basically, is it going to do through our software systems? It's going to be able to pop up at the point of sale for people who are eligible to just get us to have a vaccine counseling service or intervention.
Correct. To let you know, if they need the vaccine, prompt a vaccine counseling session, and then an immunization if you offer that immunization there. But if not, at least the vaccine counseling can take place.
Okay. Are you going to just identify the age group of the patient, or are you going to be able to identify parents that have children of the proper age?
Right now, the age group of the patient, and taking the medical records if they've had one vaccination, if they've had none there.
Okay. It would be nice if we could evolve the database to include, obviously, parents and even grandparents that raise their grandchildren. It'd be great if it would identify that link to where, because obviously that's the person we're going to have to get approval from anyway to give that vaccine. So anyway, it'd be nice, and I know databases how they work, but that would be nice to identify those people too. I think we'd get more contacts that way, because for the most part, the eligibility or ideal age group for that vaccine are pretty healthy people, so they don't come in the pharmacy that much. So
I agree. The pharmacy directors will take that back and brainstorm on that because that is a really good idea.
thank
Hey,
you.
Angela,
Thank
this
you.
is Paula. Do we have an ETA on that?
Let me get that for you, Paula, because I believe it's fourth quarter this year, but let me follow up on that.
Okay, thank you.
You're welcome.
Do we have a statewide protocol already for if they do want the vaccine? Is that out yet?
Did you hear that, Angela?
Yeah, and the one that Dr. Therio did for HPV, of course, that's for Medicaid only. Are you asking if it's for, any line of business or? I'm sorry, I don't understand.
No, I wasn't aware she had actually completed one. That was my question, if that was out and available.
We've at least seen a draft. I don't know if it's official, we're in business now with it. Let me follow up with that too.
Okay, thank
Yeah.
you.
Yeah, so
You're
I mean,
welcome.
when it's official, Angela, that would be great to get to us, and obviously KPHA and KIPA and different organizations to get that out to everybody.
Yeah, Angela, let's take that back and see when we can send out a provider notice with the protocol itself.
Does the Board of
Got it.
this is Jill from NACDS. Does the Board of Pharmacy have a protocol for HPV vaccines?
That it falls under our immunization protocols.
Right.
I mean, as long as you've got a medical director, you can do it now. We just in those meetings, we just decided that it'd be nice to go ahead and issue a statewide protocol to where there wouldn't be a barrier for somebody getting the vaccine.
Yeah, no, I understand the program. I just thought the Board of Pharmacy had one that could be used in the interim if that's what Meredith was asking. Understanding that.
Yeah, if you've already got one with your medical director, you could, I mean, that doesn't prevent you from going
Not
ahead.
the medical director, a statewide one under the Board of Pharmacy, but I'll look it up and let you know. Thank you.
It's not under, it's going to be under immunizations. It's not under this Kentucky Board of Pharmacy approved protocols.
Okay, thank you.
Okay, any further discussion on that topic? Okay, the vaccine counseling billing, Matt Carrico, if you want to make your comments.
Sure. I've been starting to try to chip away to make sure I'm getting this ironed out before flu shot season. Still working on it. Finally got a first paid claim through Passport. Thank you, Passport. One question I had was, do they have, or will they put one out, Medicaid that is, an AOB, like a standard AOB for patients to sign? Medical billing's kind of new to pharmacists, so we're still trying to figure out all the policies, procedures, and from understanding we need AOB, and I'm not really sure where we can get a standardized AOB for patients to sign before we start doing this. Didn't know if one of those were available. And then I think we were having some issues with some of the MCOs, and I was going to see if Emily Wilkerson could, I'm sorry, I forget the new last name, could step in and kind of take the lead on this because she is the vaccine counseling guru.
Yes, hi, thanks, Matt. Emily Gatewood here with the Kentucky Pharmacists Association, and Ben Mudd and myself have been chipping away at this over the last year or so. And I will say we are pretty much halfway there. We've got 3 of the 6 MCOs that are paying claims at this point, and that is Passport, Anthem, and United Healthcare. Humana, WellCare, and Aetna, we are still working to get paid claims through them. A lot of the issues that we're having are coming back to the fact that pharmacists are not recognized as a provider type, so they're the claims are wanting a referring provider that is not a pharmacist or pharmacy on the claims. My understanding is the other MCOs are getting around that by processing these claims manually. But we are working with those three MCOs to get across the finish line, if you will. Most of the MCOs are on the Availity platform, which is how we have currently been billing claims, and the pharmacies that we've been working with are billing the claims through Availity. Aside from United Healthcare, that has their own portal, and they have a form available for pharmacists to essentially sign up as providers, and then they're able to bill claims in that way. Aetna is the other one that is not on Availity. Well, I should say they are not on the free portion of Availity. You can pay $25 a month to get the Availity Essentials Plus subscription. And Aetna should be able to be available to bill once you sign up for that subscription. We have not tested that out just yet, or know what that looks like when those claims get submitted. I do worry that, at least starting out, that may be a limiting factor for some pharmacies, not knowing exactly how many Aetna patients they have, because all we can see is that their PBM is MedImpact, without looking up each patient individually. So pharmacies can't see exactly the breakdown of their MCOs. So I do worry that may be a problem starting out, but $25 a month also isn't too terrible. So it's kind of where we're at right now. Happy to answer any questions if anybody has any specific questions.
Would you, Emily, would you please repeat the three that are not, you're not having success with, please?
It's currently Humana, WellCare, and Aetna that we have not had a paid claim from just yet.
Are the ones you're getting paid claims from the payment the same across the board, or is there variation?
I don't have an exact answer, Matt. I know the price that it's supposed to be is $25 and some change. We believe we're getting paid 80% of that, which comes out to be $20 and some change. I've not seen a paid claim, an amount on a paid claim from Anthem and UHC to speak to those two. So I don't have a solid answer for you on that.
The team, have you been in conversations with Ben and Emily to try to assist with those three that are not
Yes,
paying
we
for those so
have been.
far?
Yeah, if it's not myself, it's someone on the pharmacy team that's part of the conversations and keeping track of what's going on. And I know some MCO pharmacy directors are on this call if they want to speak to some of the more specific issues, or we can handle it offline as well. But we do encourage that communication.
Okay.
And
Yeah, Ron,
we're-
this is Michael Hammond with Humana. I know I've been in contact with Ben over the past few days on working through this. We have had paid claims from other pharmacy providers. I know Ben ran into some issues as he was trying to process it through Availity. And like I said, there's been an open dialogue the past couple of days working through those issues just to make sure that it's easy. And that they're receiving the pay rate of $25.64, which should be standard across all the pharmacies.
Okay. Thank you, Michael.
Tima, do you know, is there a standardized AOB form, or do we just need to find one, or where do we find one? I'm not even sure how doctors do. I need to ask the doctors in my area, but like I said, this is kind of new to all of us.
So, I apologize, I'm not familiar with the AOB terminology, or maybe we call it something else. But it might be something that I need to follow up on, but if you can clarify what you mean by AOB, that'd be great.
Authorization to bill, basically, it's permission to bill their insurance for what we're doing.
Okay. If you can shoot that to me via email, I can certainly look into it.
Thank you.
This is Cindy at United Healthcare. I am showing on my report where we pay vaccine counseling claims that we did pay $25.64. So I think if you're getting less than that, I'm wondering if there's some sort of like, I don't know, processing fee on whoever you're using. But I wouldn't think with United, since it's our own platform. So please let me know if if you're finding that you're not being reimbursed $25.64.
I received
Thank you, Cindy.
20 change. It wasn't from United, it was from a different one, but it said that it exceeded the maximum allowable amount. And so I'm not sure if that's how we're supposed to be getting paid or not. But yeah, I was getting about 80% of the amount you stated from another MCO.
Matt, would you send with your email to Fatima, would you let her know which one that was, please?
Yes, sir.
Okay, any further discussion on the vaccine counseling billing? Okay. Just got some FYI section there that I try to let people know if any of those names change for the account executive or the managing principal at Med Impact, please let me know, Fatima, so I can update the contact information. Right now I have Jennifer Laskins Alvarez as the account executive of Med Impact, and Dean Boglass, if I'm pronouncing it right, managing principal.
Yeah, that's correct. And for any Med Impact related issues, I would encourage you all to send emails to the general mailbox for a quicker turnaround time. Not saying that these folks, won't respond in a timely manner, but it helps funnel the questions to the right individual. So I'll throw that in the chat.
Okay, thank you. Okay, under new business, this is something that's been going on in the last couple months, but pharmacy reimbursement with NADAC. I would like to clarify something that submission. We had a PBM / pharmacy owner submit low price data that pushed a lot of the prices down, and what the comment that everybody likes to make is that, well, since they're buying at such a lower rate than independents, well, my buying group buys I think it's around $20 billion worth of drugs a year. So it's not the fact of not being able to buy as low. It's just another way for this entity to hurt their competition. They're betting that they can lower reimbursement and accept it. And of course, when they're their own PBM, they don't lose as much money as we do. So I don't know if Matt or Rosemary or Meredith has any further comments on that, but to me, I mean, it's come up on the federal level and even the state level, and our we all belong to different buying groups, and we're all, when we're comparing, when we do see data, it's not the fact that it's somebody's buying so much lower than somebody else. It's other considerations are going on at the same time. Rosemary, I didn't know if you had a comment on that here.
Well, Ron, we have seen the same thing from our members. Everybody has been making these claims and, watching what's going on. And I don't know what we can do. I think we're probably going to have to go to NADAC, don't you, to go to the root of the cause and see
Right.
what's going on, because something has to be going on because it's been drastic.
Yeah.
And I think we do need to encourage all of our independent pharmacies, to submit the data to Myers and Stauffer. I know just from our aspect, at Jordan Drug, I used to get these all the time, with all the stores that we have. I would usually say, well, maybe I'm not going to submit those. Of course, that changed years ago, and we do that now. We have at least one or two a month. But I think we need to really encourage independent pharmacists, to send in the data. But something's wrong, because we are not even getting the cost of our drugs now, because the NADAC price that I have seen, I looked through our financials last night. I looked through what our 6 stores did last night, and there was very few that that the cost of our drug that I could see the cost was NADAC, what we were getting paid. It was, so much higher than that. So I don't know what we need to do, but I think as a group, we need to get together and, I don't think we could do anything at the state level. I'm not sure, Fatima can answer that, I think, but I think we just need to, get together and see what we need to do, federally. I don't know the answer, but.
Yeah, Rosemary, I would agree with that. Sorry, Ron, to cut you off. I would just like to say that, we are aware of it. Unfortunately, NADAC is fully out of our control. It's handled by CMS, and they contract with the vendor Myers and Stauffer, who manages the rates. There is a NADAC help desk that can work with pharmacy providers to better understand the methodology. Speaking of the methodology, it was updated earlier this year, and I can throw some of those links in the chat if you are interested in taking a look. And as you all probably know, any pharmacy is allowed to participate in that survey. So, I guess this time or this year, might have seen some unprecedented responses, or unexpected responses, again, out of the state's control, but we do encourage you to use the help desk and the email address that's associated.
And Fatima, just to maybe educate you on the history. I mean, this has been the problem in dealing with PBMs over my career, certainly in the last 2 decades, where we will have a pricing standard that's accepted by either the state or the federal government, and it'll be manipulated by the PBMs so badly that then somebody else or legislators or somebody's looking for, or even the Medicaid department is looking for another pricing standard to go with. And that's, we just had Representative Comer sign on to HR 9096 on the federal level. And that was his concern, and his staff's concern is that what's referenced in there for the pricing standard is NADAC. And of course, he even understands how the PBMs, because of his 3 oversight committee hearings he's had with them, that they can manipulate that pricing standard however they want to. So they find different ways to do it. So it is a real problem. I mean, it's a major problem, because, when you look at, just like Rosemary, when you look at your bottom line and see what's happened to your price, your reimbursements going way, way down, and it's supposed to be a national standard, somebody's manipulating the market. And I'm not saying it's NADAC at all, but when people have the wrong motives out there, they can do this. Another thing that's, you know, I know Rosemary and I, this point 2 here under this NADAC, the negative impact of rebated brand name drugs for us is getting to a tremendous pain point. So much so that it's a consideration to just turn away some of the brand name prescriptions because we're not meeting our matrix to get our biggest discount. And I don't know if Matt's struggling, but I sure am struggling with it. I even took those brand names out of the equation, and I'm like, well, gosh, I wouldn't have any problem making those matrix if I, you know, and we're talking about generic performance rate, brand performance rate, and generic compliance rate is what we're talking about with our wholesalers. And that is a real problem also. And it is getting to the point, you know, I'm glad that the state is making good money off of the rebates, but it's also helping to hurt the providers out there. So Rosemary or Matt or Meredith, I didn't know if you had more to comment on that.
I mean, I think you hit the nail on the head, Ron. It's definitely difficult because a lot of those stuff that's brand name is stuff that we use a lot of, such as inhalers and some ADD medicines for kids and adults. But it's making a lot of things difficult. There's a lot of things to address on different fronts with this pricing and NADAC. I'm wondering, do we know what percentage of Medicaid claims are actually paid at NADAC?
Not off the top of my head. It's something that we would have to do an analysis for.
Okay, I'm just wondering. Do you know what the second most common price point? Like, is it MAC is the second most common one, or do you know that? Or
That would be nice, Fatima, if you could get that breakdown for us, because I mean, that just helps us to evaluate.
Sure.
And that obviously could be given to the, you know, all the providers. I think everybody, normal, chain, and independent alike would like just to know the breakdown of that. Okay.
It might be interesting to look at that over the last couple of years as well, the percentage, how that has changed, not just how it looks now, but how it's changed over the last few years.
Agreed.
Okay.
But Ron, I agree with you about, you know, the brand name drugs. I mean, I think you also have to consider that, you know, we're potentially getting into a state of an access issue because pharmacies aren't going to be able, you know, to afford to stock these medications. And so, you know, unfortunately that could lead to Medicaid patients having difficulty just obtaining their medications.
Yeah. I agree. This is something that's been brought to my attention on reimbursement for long-acting antipsychotic reimbursements and admin fees. I've got 2 treatment centers close to me that are asking me about this because their patients are having a hard time obtaining the drugs, because if your reimbursement is below your cost of the drug, forget about cost of dispensing, and the admin fees, if we're the ones in charge of giving these injections every 3 months, if they're negligent or negligible, then I mean it's very hard to offer that service if it's a lose-lose proposition. So Fatima, it'd be nice if we could look at some of those long-acting antipsychotic reimbursements and see what's going on with them, because even the providers that are nurse practitioners, the MDs that are seeing these patients, I mean, they're they're frustrated because they don't understand why the people cannot get their medications because of a reimbursement issue. I mean, that, you know, everybody else works off of a different matrix system for reimbursement. They just can't understand. You know, and unfortunately, a lot of people are being told that the pharmacies can't stock the items. Well, we know what the reality is. The reality is they can't afford to stock the items when you're getting reimbursed well below your cost on them. And it's not a buying issue, it's a reimbursement issue.
Yeah, Ron, I would think was particularly egregious in this, you know, with these type of drugs where folks, if they don't get them on a timely basis or can't obtain them, there could be, you know, we could have folks falling back off the wagon and raising addiction and overdose deaths, you know, rates.
Yeah, I agree.
Is this something that surfaced because of the lower NADAC, or is this just an overall?
I think it comes around, you know, most pharmacies are getting under reimbursed on some of the most widely used drugs, and therefore, you know, are not stock, you know, will make a decision not to stock them for getting under reimbursed for them. So, and I think it's particularly, you know, it's particularly painful with these type of drugs. But as Ron was saying earlier, it's happening, you know, nationally, you know, on a state level and on a national level, everywhere, you know, all across the country with manipulations behind the scenes of drug pricing by the PBMs and driving their prescriptions to their affiliate pharmacies and paying them more than they would pay, let's say, Ron's pharmacy or a Walgreens.
Yeah, so I would say from a Kentucky's perspective and with Senate Bill 50, a lot of that has been eliminated. And I obviously only speak for the state. You know, I think perhaps in other states things work a little bit differently.
Right.
At least for us, you know, we have transparent pricing, you know, no affiliated specialty pharmacies with PBMs. So
how do you police that? How does the department know that steering isn't happening? How do you know that? I mean, how do you? I'm asking, I'm asking purely, also out of curiosity, because I know sometimes it's hard to obtain the data, even, you know, in some states. I'm not saying Kentucky's one. It's hard for enforcement because some states cannot actually get the data from the PBMs, or not the data that they actually need.
So we have complete oversight of the single MCO PBM and now, you know, the single PBM overall, even for fee-for-service members. So, you know, with that oversight, you know, we can monitor where our members are going. You know, we obviously take any concerns that come from members or providers very seriously. If someone is trying to steer patients to a specific pharmacy, you know, there's no associated specialty pharmacy with MedImpact either. So I think, you know, we've dotted our I's and crossed our T's from that respect. And if MedImpact wants to add anything, feel free.
I'm just wondering how you monitor that on a, you know, I understand what the law says, and it's a great one, and others, you know, it's a model for other states. You know, just wondering how you, like, do you run numbers every 6 months that see how many prescriptions for certain drugs are going, you know, here rather than there, or just how do you ongoing kind of enforce the rules in place?
So I guess the one thing that's different now with the single PBM is that DMS manages the provider network. So, you know, there isn't any willing provider clause, and members have the right to choose the pharmacy that they're going to, you know, as long as they're valid and enrolled within Kentucky Medicaid's network. Prior to the single PBM, as you know, we had each MCO was managing their own pharmacy network. So you know, again, we do have that oversight, and if we receive any complaints, you know, we take it very seriously and ensure that it's handled.
Okay, but is it a process where if a pharmacy feels like they are getting way underpaid on a drug, that they have to make that appeal to the department, or is it something that MedImpact kind of runs numbers on and periodically to see if the compliance is there?
So with our pricing methodology, the lowest of logic, you know, we do have ways to ensure that our claims are priced appropriately, and that is reviewed annually as well. So from that end, you know, the expectation is that all claims are priced appropriately. If there are requests for appeals, like MAC appeals, will go directly to MedImpact. NADAC appeals, since we don't manage the NADAC, those go to CMS and Myers and Stauffer. Unfortunately, the WAC and FUL, those are things that aren't eligible for the appeal process, but again, we do require the lowest of logic, and you know, the MAC appeals again can be sent to MedImpact. So essentially, from an overall perspective, the claims are monitored, the pricing is monitored, and if there are any issues or any concerns, feel free to reach out to us.
Okay, thank you. That clarified for me. Appreciate it. I'm mixing up my structures in some states, but I'm still interested in, you know, how the enforcement happens. Well, there's not, it doesn't, the issues shouldn't exist is really the answer.
Right.
The structure between DMS and MedImpact.
And this is Jennifer from MedImpact. So as Fatima stated, DMS does run the program and we only take direction from DMS. So our pricing logic is stated at the lowest of. There is no pricing manipulation. We use what we get from First Data Bank and Medispan, as well as the information, you know, the FUL and the NADAC come from CMS, fed through those vendors. So there is no changing in pricing. And then all of our preferred products are presented to DMS. They are the ones who make the decisions on all of that. There is nothing done that they are not aware of. We are 100% transparent.
Thank you. Sorry to take up folks' time on that.
No, it's fine. Some good questions. And also, Fatima, I have not known any pharmacist who's been able to bill for any of the long-acting antipsychotic reimbursement or injections, because a lot of the doctors' offices and counseling centers that have nurse practitioners and MDs, they realize that our hours are a lot more flexible and are more open more than their offices are, because a lot of these are kind of regional places, and they may be here Monday, Wednesday, and Friday, in another county Tuesday and Thursday. So they do want the help of the pharmacists being able to administer these antipsychotics and for that matter, Vivitrol and different things that they're needing our help on. So I'm not getting any feedback from pharmacists that they're actually being reimbursed for those admin fees. So I will send an email to you and give you some examples of drugs that pharmacists are delivering for, administering for these particular prescribing providers, because of just lack of patient access to their offices, because they're covered up as they already exist, just trying to meet the demands of mental health.
Sure. And you know, just from that perspective, if there is a request to look into that further from our end, it would require a fiscal analysis, leadership approval, and possibly a reg change as well. So just wanted to put that out there as kind of the process that we would take to look into something like that.
Okay. Well, hopefully you all can understand the flexibility and greater access that patients would have in us helping to manage that patient's therapy, especially when a lot of these clinics are only open for certain days and certain hours in different regions of the area, especially in rural Kentucky.
Sure.
And the cost savings that's involved in keeping these patients on these medications and not relapsed.
Right. Great point. Fatima, the next topic there is, well, I'll tell you what, can we please have an action item on that, Meredith, that we would like for Medicaid to look into the admin fees on non-vaccination prescriptions for antipsychotics, for substance abuse injections?
So moved.
Okay. First motion by Meredith,
I'll second.
second by Rosemary. Any further discussion? All those in favor say aye.
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 Any opposed? Okay, thank you. Okay. And then Fatima, what is the proper procedure for changing a patient's lock-in status? Because that's something that pops up ever so often, that somebody wants to come to our pharmacy and is locked in somewhere, and it takes quite a bit to get that changed.
So I will defer that to our MCO partners. It's a program that they manage. The other thing I will say is that we have a provider communication that will be going out in the near future that outlines each MCO's lock-in policies and how to get in touch with the respective MCO. Just helpful fact sheet, if you will.
Okay. Does any of the Med Impact people on the call today want to?
So yes.
Yeah, MedImpact's not the managed care.
Well, and it may vary by MCO, but this is Cindy at United Healthcare. The member has to call to request a pharmacy change, and they need to call, whichever MCO. So for United, it would be for United, and then that's usually done within one business day, typically within just a few hours. But if it's on a Friday and it comes in late, it could be a problem, one business day. So it might not be taken care of until Monday. And I'll let the other MCOs speak to that.
Okay, thank you.
For Passport by Molina, it's also required of the member to request that change. And we also strive for a 24-hour turnaround.
Okay, thank you.
The same for WellCare as well. A member can call in, or their care manager if they're, we try to enroll all of our lock-in members into our care management team so they can help facilitate that change as well. And again, we adhere to a 24-hour turnaround time.
Yeah.
Hi, and this is Levita with Aetna. It's the same process as well. You have to call in, the member has to call in and request it. And again, 24-hour turnaround time.
Is that just the phone number on the back of their card?
For Aetna, yes, it's our help desk that will get in contact with our
help desk. Okay.
Yep, same for WellCare.
Okay.
And this is Angela with Anthem. It's the same process for us.
Okay.
Yeah, this is Michael with Humana, and we actually have the person that runs our pharmacy lock-in program on. Margaret, are you able to speak to what our process is?
Yes, this is Margaret Johnson from Humana, and we did the same. The member must give us a phone call to request a change of pharmacy, and we strive for a one business day turnaround time.
Okay. Thank you. I think we've already discussed D up above there. And we're going to be working on that. And then I just listed some things that it's kind of odd in our nation right now that different states have different medical billing regulations and rules and opportunities for pharmacists in certain states, and in another state they don't. So it's kind of like if you get a program going with ABC insurance for diabetes self-management education, or even compliance counseling, or any of those I've listed there in one state, and then that same ABC insurance in Kentucky or another state, it's like starting all over again with the process. So that's been a really tough nut to crack there, trying to figure out the inroads, because you would think that if you're talking about a national insurance company, that you could just refer to the fact that, okay, this is going on in Texas, but again, that's very difficult. So I didn't know if any of the MCOs would be or be interested in commenting on that. It's just a real, I guess, frustrating point for us in trying to, House Bill 48 was passed in 2022, and we've been trying to, get paid for various clinical work that we do. And it's just, other states and even Kentucky, Kentucky's may have something that we're getting paid for, and in another state struggling to get that same thing with the same insurance. So anyway, I didn't know if anybody wanted to comment on that or not. Or if anybody on the call period as pharmacists would want to comment, because just seem to keep breaking down the same barriers that have been broken down in other states. Jennifer, did you want to say something?
Oh, I was just going to ask a clarifying question. So are you basically saying, like, why does Anthem not have the same coverage across states since they're the same insurer, or?
Yeah, I mean, and again, not, since I've been in this world 33 years, but yes, that's exactly what I'm talking about, is that, they may start paying for a service, whatever the service is, in another state, but in Kentucky, they don't. So I didn't know if you.
And I'm going to base this off an assumption, and I don't know if anyone else wants to speak to it, but most of the time, any insurers contracted by someone, just as PBMs are. So Anthem, from a medical claims perspective and a PBM perspective, would be contracted by a client who then makes the decisions on what's covered, what's not covered. So unfortunately, it's not a national, just as Medicare D plans, they can be national, but they could have different coverage depending on which plan you choose. So, I mean, I think that's a bigger than us problem.
Okay.
This is Cindy at United. I think, Ron, that it varies by state, so different states have different priorities. And so in Kentucky, where the state is covering vaccine counseling. In other states, they might have chosen tobacco cessation or MTM, just speaking from, what, I guess, what's covered in some of my, some of the other Medicaid pharmacy director states. So that, I think it's just a question of, state priorities and budget, because it is always a budget concern as well.
Okay. And I'll send some information to Fatima on what I'm talking about a little bit more in detail. So, but I appreciate your answers.
Good. And just to echo the budget piece of it, There are different budgets across the board depending on lives and, well, really the lives is the most important thing, is how many members do we have in our Medicaid bucket. So, you know, just from that perspective, the federal match and just a lot of factors that play into how much money each state receives to manage their Medicaid programs. So a lot of that needs to be analyzed by our finance team, you know, before we can make any drastic changes. So just wanted to make a note of that.
Okay. All right. I didn't have anything else on the agenda. And I forgot, Aaron, to put the date of our next meeting down. If you're on here, because we had to postpone this one a couple weeks. If Aaron's still on here, or if not, I can certainly.
I am. Give me just a second. No,
I apologize.
October 2nd.
Okay. All right. We'll be working on that.
Is put to the MAC like the first motion for Meredith for CHW or anything that we've done, or is everything automatically getting sent to the MAC?
Yes, between me and KPHA and Kathy Hanna, we make sure that that is representative to the MAC. And if I can't do it, they do allow Kathy to mention it, and I usually send out an email to all of you all on the PTAC if somebody else can present it, if I can't.
And one other thing, to circle back on our last point about medical billing in other states, and I understand the budgetary concerns within our own state. Do we know what, if any of these programs that are happening in other states have resulted in cost savings for the program?
I don't have that data, but certainly I think that's why you have places or organizations like CPSN and different ones that are trying to compile that data to show the cost savings. So I don't know if Fatima has a resource for that or not.
So, you know, the states that do cover it, I'm not sure if they've published any cost savings data. But you know, if you all have any, we'd be happy to review it.
Okay.
And Ron, this is Aaron. If you don't mind to follow up those recommendations in writing for me, just to make sure I capture everything appropriately.
Okay, I sure will.
Thank you. I do my best, but not being a subject expert, sometimes I struggle.
No, that's fine. No problem. Okay. Do I hear a motion to adjourn?
Make a motion to adjourn.
Okay.
I'll second it.
Rosemary and then Paula. Any further discussion? All those in favor say aye.
Aye.
Any opposed? Thank you all. Thanks everybody on the call.
Thank you.
Have a good afternoon.
Bye, guys.